Local programming on KRWG made possible in part by viewers like you. Thank you.
Welcome to Fronteras, a Changing America. I'm Edmundo Resendez. My guest today is Dr. Mota-Castillo, who was born and raised in the Dominican Republic, where he attended medical school and came to the USA in 1980. Trained in general psychiatry and child-adolescent psychiatry, as well as family therapy in New York City, Boston, and Phoenix, Dr. Mota-Castillo has published 2 books and multiple papers in psychiatric journals. Dr. Mota is the Chief Medical Officer at Mesilla Valley Hospital and is Chair and Psychiatric Program Director at Burrell College of Osteopathic Medicine at New Mexico State University. Today we explore bipolar spectrum disorders, the Cinderella of mental health, with Dr. Mota-Castillo. Dr. Mota-Castillo, welcome to Fronteras, a Changing America.
Thank you, Edmundo. It's a pleasure.
Let's start the conversation by a presentation that I went to see you do at Mesilla Valley Hospital a couple months ago. And what caught my attention is how you describe bipolar spectrum disorder. You describe it as the Cinderella of mental health. Why is that?
It is because people and the psychiatric establishment has completely ignored that concept that has been around for more than 30 years and which is really what make justice to what bipolar is, because many people, including doctors and other providers, have the impression that bipolar is just one thing. And it is a spectrum, like you talk about the autism spectrum. There are autistic children that don't even talk. And there is a famous autistic person, a lady, who is a doctor, and she talks, and she had a special on HBO. So it's the same with bipolar. And if we don't understand that it is a spectrum, we are going to miss the majority of the patients with bipolar and treat it for something else. And that something else could be depression, that many times is described as treatment resistant because they don't respond to antidepressant, or depression plus anxiety, or personality disorder, when the real issue is soft bipolar that does not comply with the guidelines in DSM-5 and previously DSM-4. If you apply the concept, the rules to diagnose bipolar to those individuals who don't have a serious bipolar that goes from very depressed to manic, then they are orphaned, they are ignored, they are Cinderella.
Well, let's talk about an important topic that comes with mental health disorders, and that's the topic of medication and the pharmaceutical tie-in. You disclose in your presentation that you have no ties to pharmaceutical companies. Why is that important for you to disclose, and is that something that you look at because you feel that there might be overprescribing medications to patients?
Well, I think there is overprescribing, but not because of any money interest. There is overprescribing because most of the time they are aiming at the wrong target, and they have to use multiple medication to try to control the symptoms. But saying I have no ties to pharmaceutical companies is saying my presentation is unbiased, because there are many colleagues that give presentation that are sponsored by a pharmaceutical company, and obviously they are going to favor that company's products. Also, there are famous people in the United States that conduct research study, and they receive serious amount of money from pharmaceutical company. This has even been the subject of, for example, a Boston Globe front page in about 4 or 5 years ago. And also there was a chairman of psychiatry from Ivy League university that was dismissed because of conflict of interest. But for the most part, most doctors don't prescribe because they receive money. We are not even allowed to get a pen.
Not
Before,
anymore.
not anymore. The pharmaceutical, we had those fancy pens that I will give to doctor, or they will invite for dinners to presentation, and you can bring your wife or your friend. That's not allowed anymore. And I think that that's an extreme, because we are not going to sell our judgment for one pen.
Well, let's talk about bipolar spectrum disorders. And could you explain to us tonight, and explain what bipolar spectrum disorders are? You know, this was once called manic depression. What is the best way to describe bipolar spectrum disorders?
If we consider that my favorite example is the dog.
Okay.
You know, we call dog a poodle, a chihuahua, a German shepherd, but also a Rottweiler or a pit bull. We call with the same name one animal that will sit on your lap and would like to be gentle and friendly, and the other that will attack you, can even kill you. And that doesn't make justice to the diagnosis of bipolar if we don't introduce the concept of a spectrum, because the individual who is very successful, who is a famous artist or a politician or a doctor or just a regular person who is successful in whatever he or she does, probably doesn't feel comfortable when the name bipolar is given to the same person who is on the street saying that he is Christopher Columbus, or she is the Queen of England, and carry all his or her belongings on a back, is homeless. To use the same word for both of them is just not right.
Okay.
There are degrees of severity, like in other illness, physical illness. We call diabetic a person who controls his blood sugar with diet or with one pill. We call diabetic a person who needs to inject insulin 4 times a day and is in kidney failure and has heart problems. And it just doesn't express the degree of severity. One person can be bipolar and be completely successful. Another person can be bipolar and be a train wreck. More so when they combine the bipolar with substance use.
Is that to do with not being diagnosed, that they are train wrecks, or they are diagnosed and choose not to actively seek medicinal and talk therapy?
Okay. Well, it's a little bit of all of the above, because some people, and there was a study done by NAMI, the National Association for the Mentally Ill, that was directed by Dr. Hirschfeld, who is a famous psychiatrist. And they found, by surveying the members of NAMI, that it took about 6 to 10 years to 80% of the people surveyed to get the right diagnosis. After seeing a medical provider, either a primary care physician, a psychologist, a counselor, or a psychiatrist, they didn't get the right diagnosis, 60% of them, for 6 or more years. Then if you don't have a right diagnosis, you're not going to get the right medication. And I had seen many cases when a person has clear-cut bipolar and is being treated for depression, and never get better. And those, most of the time, are the people that are called borderline personality disorder, because the talk behind doors among psychiatrists and therapists is that borderline never get better, which is not true. I had many stories of borderline, so-called borderline, that when you diagnose them correctly and don't give them antidepressant, they get better. There is also the other part, the people who choose to use drugs, especially those who use cocaine, amphetamine, stimulants, which will make the bipolar even worse. The marijuana or the opioids actually help with the bipolar, but they are no good treatment for the same reason that alcohol is not a good medication. You can be manic, you get drunk, you come down. But you can't drink and get drunk every day. Not only it's not going to let you function, but it will destroy your liver. But at least those sedatives don't worsen the bipolar. But the stimulants, even caffeine and cigarettes, they will make the bipolar worse.
Let's talk about some common prescriptions that are given to people that have been diagnosed with bipolar disorder. What are they, and what are some common prescriptions that are given to somebody who might be misdiagnosed as just being depressive?
Well, there are some popular medication right now, antidepressant that had come up. Do you want me to mention brand
That's
name?
Fine. Sure.
Okay. For example, Brintellix is one of the newest antidepressants. And there are other that are used, for example, Cymbalta, which is prescribed very frequently for fibromyalgia and for other type of pains. And this is when the communication between doctors is so important. Because, for example, a psychiatric patient is being seen by a psychiatrist and then go and see a rheumatologist who is not aware that the patient is bipolar and prescribe this potent antidepressant, who also is a pain medication for neuropathic pain, which is also given to diabetic because they develop neuropathy, which is very, very severe pain. And they will get worse. The bipolar condition, they will get more irritable, aggressive, hostile, insomniac, can't sleep because the mind races so fast. So, and that's one hand. When we have new medications that had come up recently, like Latuda, is very popular. It's a mood stabilizer that is also an antipsychotic. And that is a safe medication because if you are depressed, it helps. If you are bipolar, it helps. And it's the case also with Abilify, with Zyprexa, Risperdal. But we have to be aware of those medications have side effects. For example, Zyprexa, which is a incredible effective drug, and I even was involved in the trials when it was just a number, has no name, has nothing against the medication, but if you take it for a long time, you're going to gain a lot of weight. You can develop diabetes, hypertension, other problems. But for acute use, it's a very effective medication. There are other that don't give you weight gain, increase appetite, but has other side effects like sedation, tremors, shakings, and not necessarily to everybody, but some people react to those medications with side effects. In general, we just need to see every individual as one person. We don't have a medication that is good
For everybody. There is no cure-all.
No, there is not.
Okay. Well, let's talk about the challenges that exist between mania and depression, because you have to, have a stabilizer that a patient will be taking, but once they get in a manic stage, you have to treat it differently. Can you explain how that works?
Okay. Well, I'm glad that you mentioned the word mania, because that is very important for the audience to understand that mania not necessarily means being high and happy. That's the happy mania that we would like to have, being on top of the world. But there is an agitated called dysphoric mania, where you are high, but angry, upset, frustrated, can't sleep. And that's the most dangerous. That's most of the people that commit suicide are on agitated dysphoric mania. But it's mania. And many people get confused when they are told, you are bipolar, and they say, but I never experienced mania. Well, they are thinking of the happy mania, and there are two public figures. One unfortunately passed away. Robin Williams was always happy. But another person who came public and say, I am bipolar, was Jean-Claude Van Damme. And I don't remember seeing him euphoric or very happy. He was the tough guy.
Yes.
Oh, he is the tough guy in the movies, and that is also mania, but it's an angry mania. Now, for mania, either happy or angry, we use the same medication. And we usually combine a mood stabilizer, like one seizure medication like Depakote, Tegretol, Lamictal, or what are called second-generation antipsychotics. And this is where it falls Risperdal, Geodon, Zyprexa, Latuda, and all the new ones. But we have to stay away from antidepressant.
During that time, during the manic stage?
Even during the depressed state.
Okay.
Because what happened is that this new generation of antipsychotic are called atypical because they have an antidepressant effect. You put a person on Abilify or Latuda or Zyprexa or Risperdal, and this medication treat the depression. And we have seen the commercial of Latuda and Abilify being advertised on television for depression because they have an antidepressant effect.
There's so much to talk about, and unfortunately we don't have a lot of time, so we kind of have to jump around a little bit, but let's talk about diagnosis in children and adolescents, because that is something that is brought up. Is this something that could be passed on to the children with somebody that might have it, and misdiagnosis of children who might be diagnosed as ADD or ADHD?
Let's put it simple for the sake of time. Bipolar is one of the most inheritable conditions. And it starts early in life. And these children are usually misdiagnosed as having either ADHD or oppositional defiant or conduct disorder. But I had actually published a few papers on this area, and if you don't mind, I will mention that I have a website for the public.
That's fine.
Psychiatricanswers.com. You can go there and read it on the importance of genetic, and also on the fact that it happens in children. It's just different. The symptoms are the same: elevated mood, impulsivity, insomnia, hostile behavior, talking out of time, being fresh. It's the 7-year-old that asks the teacher out, or the 5-year-old that stands in front of the father and say, no, I'm not going to do it. He's here and the father is there. There is no awareness that, hey, this guy is 4 feet taller than you. you know, and the same with adult, you know, it's just different circumstances, but the criteria for diagnosis is the same. Just a child is not going to be driving a car at 80 miles on the highway, you know, or jumping naked on a swimming pool in front of people. Well, maybe a child will do it.
Well, a child would do it. But, you know, how often is this passed off as, well, the child is just being a child, you know? What age should a parent start to get concerned? You know, is it through the teenage years where a parent can really start saying, wait a minute, there's a pattern that's happened since the child was an adolescent, now that they're going through teenage years?
Well, my suggestion is that we start to treat the child as early as the symptoms appear. And there are very safe medications. There is no excuse not to use it because, for example, Lamictal is approved for the treatment of seizure, convulsions, in a 1-year-old. So if you can use it for treat seizure, why not to use it for treat mood or irritability? And I want to alert parents that children sleep. You have children, and you know that by 8 o'clock, a 5-year-old or a 6-year-old is looking for bed. If it is midnight and a 4-year-old is not looking for sleep, something is wrong. And that's usually one of the first warning signs. A child that in a daycare punch another child for no reason, you know, and is very aggressive for no reason, without provocation, something is wrong. You should check it out.
Let's go through some misperceptions as to what bipolar disorder is. You know, there is a song by Katy Perry where she talks about being hot and cold. You know, bipolar disorder doesn't work that way, where you're hot and cold one day.
No.
It's something that happens over a period of time.
Yeah. And not everybody get hot and cold. Some people are always cold and some people are always hot. And there are people who most of the time are manic. There are people most of the time are depressed. There are people who are in the middle, depending on the severity of symptoms. Some people with bipolar just simply can't sleep well or are impulsive, talk out of time, say things that they regret later, but they are not impossible to be around like other people. That you can say the nicest thing and they take it as an offense or get paranoid. That's the extreme. But there are others that are very subtle. And there is the rapid cycling. There is, but it's uncommon. There is the person who is hot in the morning, cold at noon, hot in the afternoon, and maybe cold at midnight. But that's very rare. Most of the people is like you say. There is a transition from one period to the other. And most of the time, the person can feel the change coming.
How often do you encounter a patient, or have you encountered a patient, and how common is it to have somebody that you've been treating who feels cured after taking medication and feels as though they no longer need to take the medication and get off the medication?
That's a very, very common mistake.
And you know, how challenging is it to bring them back?
Well, sometimes it's difficult because many people enjoy the high, you know, or some people never come back because something bad happened during that period. They are killed, they are kidnapped because they engage in risky behavior. I remember a patient that I had many years ago that has been stable on lithium, which, by the way, is one of the best medications that I didn't mention. And this person was stable for many, many years, successful in business, successful in society, and stopped the medication. You know, after 20-something years, I should be okay. After a few months, mania. End up in Las Vegas. I'm not going to go into more detail, but the situation wasn't good. You know.
Let's talk about your theory that you discuss, which is at least do no harm. Can you talk about that?
Well, yes, because that's something that we need to be careful, not only in psychiatry, in any specialty. If you are not sure what the patient has, you have doubts if it is bipolar or schizophrenia or depression or PTSD or anxiety, panic attack, try to use a medication that is not going to make it worse. For example, a very popular medication is Wellbutrin, bupropion. It's a medication that is like drinking 5 cups of espresso one after the other, a 300 milligram dose. If somebody has anxiety, what happens if you drink too much coffee?
You get shaky and you
Exactly.
get antsy.
Exactly. You don't need to be a psychiatrist to know that. So, but I see, unfortunately, many people with anxiety that get Wellbutrin because the doctor is looking at Wellbutrin makes you lose weight and you are overweight. Well, coffee also decreases appetite, and this is the type of thing that doctors should not do because it will harm that patient. If you are overweight, stay away from Zyprexa if you can. Choose your medication, make it custom made.
As we wrap things up, why don't you give us the name of your website again, where people can go to get more information?
It's very simple, psychiatricanswers.com.
Well, Dr. Mota-Castillo, I want to thank you very much for coming in and discussing this important issue of bipolar spectrum disorders.
It was my honor.
And we'd love to have you back again.
Thank you very much.
For Fronteras, a Changing America, I'm Edmundo Resendez.